Prof, you can start now.
Can I start?
Yes.
Dear colleagues, ladies and gentlemen, good afternoon. I'm very much pleased and honored this afternoon to have a special session on the Mycetoma Research Club. I'm very delighted, thrilled to introduce to you Borna. Borna, she is one of the very fantastic scientists. She supported the Mycetoma Research Project tremendously. Currently, she is the director of the Mycetoma program at the DNDi, Drugs for Neglected Diseases Initiative. She is our star. She helped us during this difficult time to excel and to continue our work on mycetoma. She is a very close friend to the Mycetoma Research Centre and the community. She managed to go to very difficult areas in Sudan where mycetoma is endemic, spending a lot of time with the people there, with the patients, trying to help and support our program. And she and her group conducted with the Mycetoma Research Centre the first ever double-blind clinical trial for a new drug for mycetoma patients. We are very much grateful, honored, and pleased to have you in this session of the Mycetoma Research Club. Before we start the presentation, I would like to announce a very important event took place about 2 days ago. Our eminent, enthusiastic, active, young research assistant at the Mycetoma, she was awarded an Outstanding Early Career Achievement Award. Samira, please tell us about this fantastic Outstanding Early Career Achievement Award.
Thank you so much, Prof, for this introduction. This award was it's directed towards women and for people excelling in their fields, influencing people. So it's under an umbrella of the most influential women, and I was fortunate enough to win the Outstanding Early Career Achievements Award. It was given by the World Association for Sustainable Development in the United Kingdom.
Yeah, thank you very much. I'm sure this will be a very good plus to continue doing the good work you are doing to improve the quality of the life of people around the globe. Thank you very much. Let us all congratulate Samira for this achievement, and we're looking forward for more achievement and more activities and more in development for your career and activities. Borna, the floor is for you. Thank you very much for being here with us this morning. Thank you.
Thank you so much, Prof. Fahal, for that wonderful introduction, and congratulations to you, Samira.
Thank you. Thank you, Borna.
So I'll start my presentation. I hope you can see my screen.
Yes, it's clear.
Yes.
Okay. I will start just by introducing neglected tropical diseases. We tend to talk about mycetoma quite a lot as a unique NTD, but just taking us back on what neglected tropical diseases are and what DNDi does. Neglected tropical diseases are a group of preventable diseases that usually affect marginalized and poor populations who live in remote areas, urban slums, or conflict zones. We tend to think of this as a very small number, but over 1.7 billion people across the world are affected by neglected tropical diseases, and almost all countries in the world are endemic for at least one NTD. But unfortunately, due to these neglected populations that affects, and them not having quite a lot of financial or economic power, there is little financial incentive in supporting desperately needed medical research. And we find that almost 40% of this global burden of NTDs is in the African continent. Unfortunately, also, we are also doing among the least research and development programs. And this means that the people who are affected are not getting treatments that are affordable to them, that are effective, because this is not a priority across the world. What is DNDi? Drugs for Neglected Diseases was created as a frustration of clinicians and desperation of patients faced with medicines that were ineffective, unsafe, unavailable, unaffordable, or that had never been developed at all. As I mentioned, since there's no financial incentive for most pharmaceutical companies to take part in research and development for drugs that patients might not be able to afford, DNDi thought this was a gap that needed to be filled, where the prevailing profit-oriented model for medical research leaves little incentive to develop drugs for the poorest and most vulnerable communities. The three pillars of DNDi are: one, to innovate to save lives, where we discover and develop urgently needed treatments for neglected patients, where we ensure they are affordable, available, and adapted to the communities who need them. We foster inclusive and sustainable solutions by working hand in hand with partners in low and middle income countries to be able to strengthen innovation ecosystems, and we advocate for change. We speak out for policy change to enable more effective and equitable research and development, so that no matter the income of these patients or where they live, they have access to the fruits of science. We are working in over 10 neglected tropical diseases, in sleeping sickness, leishmaniasis, both cutaneous and visceral leishmaniasis, Chagas disease, river blindness or filariasis, mycetoma, dengue. We've been working in pediatric HIV and now are working in advanced HIV disease. Hepatitis C is not a neglected tropical disease, but a lot of the patients who were affected by hepatitis C were not getting affordable medicines, and this was a gap DNDi felt that it needed to fill. COVID-19, which now progressed to the pandemic-prone diseases, because at this particular time, a lot of resources were not being put within the African continent and other low-income countries in terms of drugs that would be applicable to them. And we're exploring other areas such as schistosomiasis and snake bites. We've been able to develop 13 new treatments for 6 deadly diseases. Our most recent is fexinidazole, which is a much safer treatment for TB rhodiense, less common but a more acute form of the disease. We also have a safer treatment for visceral leishmaniasis in Latin America and also in Africa that have been developed. These developments have begun from 2007 when we first released artesunate and amodiaquine and artesunate and mefloquine for malaria. And this was now removed from the portfolio as we now concentrated on the other neglected tropical diseases. How are we working through this? We work through our partners. We have over 225 research and development and access partners in 47 countries. We have 68 clinical sites in 25 countries, active in 8 disease areas, with 9 offices on 5 continents. We have offices in New York, Rio, in Nairobi, where I'm based, in Kinshasa, Cape Town, an office in India, Malaysia, and Japan. And with this, we're able to manage quite a number of clinical trials. We work with our partners who implement these clinical trials, and we are in partnership with our founding partners, including Institute Pasteur, Médecins Sans Frontières, KEMRI, and the Malaysian Ministry of Health, who are among our other partners who have enabled us to be able to conduct our activities. So going into, when we talk about financial incentive and why we do not have a lot of work in research and development for neglected tropical disease, just as a basic of understanding what this research and development pipeline is. The pipeline can last from 10 years. Is that a question or? The pipeline can be quite long, from 10 to almost 15 to 20 years, depending on the different stages where the drug is. Starting from discovery, where we have the chemical compound, where we conduct screening, evaluation, and optimization. With this preclinical work from the drugs, whether they are new chemical entities or whether these are drugs that are repurposed. Then we have our in vivo and in vitro testing that is usually conducted before we go into the drug candidate assessments and going into the clinical trials, starting with our phase 1 clinical trials, where we look at the safety of the drugs in healthy volunteers. This is in our phase 1 clinical trials. Then we move on into larger scale clinical trials, phase 2, 3 trials, which can last 5, 6 years, where we look also at the safety, but also at the efficacy of these drugs. Then finally, we go into the implementation stage. Because after developing the drug, we need to ensure that the regulatory authorities have reviewed these drugs. There's national registration, and there's also ongoing surveillance to be able to pick up any safety issues. And also we look at any barriers that need to be tackled to prevent, that would prevent access of these medications. Because as we have learned, there's no use to go through this whole process of developing a drug, then the patients not being able to access it. So we need to ensure that the regulatory authorities understand the work that we're doing. The stakeholders such as the ministries of health, the pharmaceutical industries that we're working with, and also the treatment providers. These are the physicians, the healthcare practitioners, are also able to prescribe these drugs so that we can be able to treat the patients that require it. Going into mycetoma specifically, this is a chronic disabling bacterial or fungal disease, and it is characterized by massive deformities and destruction, which leads to loss of function. Looking at the patient on the right, this is from the Mycetoma Research Centre, seeing that most patients, unfortunately, who present to the hospitals usually come at a very late stage, and amputation at that particular time is their only option. So we have centers such as the Mycetoma Research Centre, which were able to go within the communities and identify patients with mycetoma at very early stages. And with this, they were able to get treatment and prevent amputation. But we've seen in other endemic countries where the awareness of mycetoma is not as much, people still present to hospitals or to healthcare facilities at very later stages. With this, then, we see massive morbidity, disability, and of course, psychosocial impact on the patients, their families, the communities, and the health systems in the endemic regions. Because we know the people who are most affected by this mycetoma are either farmers or herders or pastoralists, people who need to be moving around. They are the providers of their family. And of course, if they're not able to provide for their family, we have this perpetuating cycle of poverty. Of course, apart from the physical impairment, we have socioeconomic problems, stigma, significant mental health consequences, reduced quality of life, and of course, if these recurrences are not dealt with effectively, it leads to mortality. With the two types of mycetoma, actinomycetoma, the bacterial infection, we know it has a greater than 90% cure rate using antibiotics. But Mycetoma, for the longest time, the case reports that have been available have shown the cure rates with antifungals were less than 40%. In terms of the disease itself, we have basic epidemiological information that is lacking, with the global burden remaining unknown. We have quite a number of literature that has tried to model some of this, but we do not have specific data on the global burden of the disease. As mentioned, it affects poorest of populations in remote areas, field laborers, herders. These are young adults with high morbidity for years, of course, as mentioned, with a huge social impact, no partners, no work, with stigma. Currently, there's no definitive theory about the route of transmission. Of course, the Mycetoma Research Centre, most of the data that we currently have is from Sudan, where they have been able to conduct quite a lot of studies, trying to also understand the prevalence within Sudan and within certain areas, the pathogenesis of the disease, and also some of the environmental factors that affect patients with mycetoma. But there's still quite a lot of work that needs to be done. The current treatment for mycetoma, the fungal mycetoma, is long, ineffective, expensive, and has serious side effects, and we still do not have a point-of-care diagnostic test. So going into our world's first randomized double-blind clinical trial, of course, looking at the challenges in which the drugs were ineffective, toxic, and unaffordable, and where for severe cases, the only option is limb amputation, there was a great need to be able to conduct a clinical trial to be able to find a safe, effective, and affordable treatment. And the goal for DNDi is to be able to prevent devastating amputation and disability of patients by developing this safe, effective, and affordable treatment that would be accessible for all people in need. And with this, we looked at the antifungal drugs that are currently in use for the treatment of mycetoma. This table is modified from the online survey that was conducted by WHO in 2023. We find that itraconazole is still the most frequently used antifungal at 85%. It is quite expensive, specifically for the trademark itraconazole. The generic itraconazole that might be cheaper, we've seen quite a number of them have a lot of quality issues, of course, which has an impact on the efficacy. And for those who have access to itraconazole, you find that it is not always available, hence compliance with the drug becomes much harder. Drugs such as terbinafine is also the second highest used, is used for refractory cases, but also quite expensive. Voriconazole at 41%, there's limited data available and few case reports show a good response. So if you notice these three most commonly used, they're actually not approved for the treatment of mycetoma. The two drugs that are actually indicated for the treatment of mycetoma are posaconazole and amphotericin B, which is rarely used due to toxicity requiring intravenous administration. And a drug like posaconazole was actually approved based on only retrospective data from 5 patients. And we know in terms of data that would require registration, it would be good to have a drug that has much more data associated with it. Ketoconazole, unfortunately, is still used quite a bit at 30%. Even though it was removed from the WHO Essential Medicines list in 2000 and alerts issued by the WHO because of hepatotoxicity. Then we have other drugs such as fluconazole, griseofulvin, isavuconazole that are being used, even though we do not have specific data on the efficacy of these drugs. Going into fosravuconazole, this is a drug that was developed by Eisai Pharmaceuticals in Japan. It is a new azole antifungal. It's an aldosterol biosynthesis inhibitor, which has high solubility in water, high oral availability, and rapidly converts to ravuconazole after administration. So it's good in terms of it can be used both intravenously and as an oral formulation. It has a long 8 to 11 day half-life, which allows for once a week dosing. And we initially used it at DNDi for the treatment in a clinical trial for the treatment of Chagas, and was found to also have activity against Madurella mycetomatis, which is the most common causative organism for Mycetoma, and that is what advised us in using it for our clinical trial. So looking at fosravuconazole, we compared it to itraconazole, which is the most commonly used treatment for Mycetoma. We found it had a minimum inhibitory concentration of 0.00016, which is 16-fold stronger than itraconazole. As mentioned, it has high solubility, allowing both oral and intravenous formulation, while itraconazole has low solubility, which causes variation in absorption. The half-life, of course, allows for once a week dosing with no food effect, while for itraconazole, it needs to be taken after a meal and needs to be dosed twice daily every single day. We have fosravuconazole is a moderate inhibitor of cytochrome P450 so it has minimal drug-to-drug interactions, while itraconazole is a strong inhibitor, and we have quite a number of contraindicated drugs for itraconazole. So we found that in real clinical settings, itraconazole is not easy to use, mainly due to this high risk of DDIs, the low solubility, and a food effect that causes variable absorption. So we saw that fosravuconazole is a highly mature antifungal agent that has high solubility, potent antifungal activity, high safety, and long plasma half-life. And with this, we conducted this phase 2 clinical trial where we were comparing fosravuconazole 300 milligrams, fosravuconazole 200 milligrams, and itraconazole 400 milligrams daily, while fosravuconazole was weekly. We looked at sorry, I'm seeing some activity on the screen. We looked at the patients after we had 28 patients per treatment arm, resulting in 84 patients at the interim analysis, where we were supposed, as per the study design, to drop the loser. The loser being either fosravuconazole 300 milligrams or fosravuconazole 200 milligrams at the interim analysis. The Data and Safety Monitoring Board did review this, and they found that there was no loser arm, and they recommended that we continue with all 3 arms. We continued with all the 3 arms, and at a patient 104, we had a second interim analysis, and the DSMB, the Data and Safety Monitoring Board, reviewed the data. In this clinical trial, we were looking at the superiority of fosravuconazole over itraconazole. As I mentioned from the case reports, we had expected itraconazole to have cure rates of less than 40%. And this is what had been indicated within this clinical trial, a 40% cure rate estimated for itraconazole at the end of 12 months based on the limited case reports. Our primary endpoint was complete cure at 12 months. That was evidenced by clinical assessment, which showed absence of mass as we were removing, we were conducting a surgical excision at 6 months, and then a normal ultrasound or MRI, and then a negative fungal culture from a surgical biopsy if a mycetoma lesion was still present. The clinical trial was conducted from 2017 and was completed in 2021. We had our results that was published in the Lancet Infectious Diseases last year. It was first published in August, and it was in the Lancet ID issue of November 2024. The modified intention to treat population, we saw that fosravuconazole had an efficacy of 50%, 300 at 50%, 200 at 64.7%, and itraconazole at 75%. So as you can see, why the DSMB had indicated for us to stop the trial at that time, because we would not have been able to have shown the superiority of fosravuconazole over itraconazole. And we see within this particular situation that when you are able to ensure compliance within the patients, that is them taking their medication every single day, they have access to this itraconazole, that we can have actually efficacy of itraconazole for mycetoma at greater than 75%. But within the protocol population, we saw that fosravuconazole 200 milligrams had an almost 85 efficacy rate. So we saw with this that this investigational drug, fosravuconazole, it demonstrated no new safety concerns with its lower pill burden, along with the reduced risk of DDIs. Compared to the costly and less accessible itraconazole, it would make a strong candidate for use in clinical settings. So we are currently working with the Mycetoma Research Centre and the regulatory authorities in Sudan as soon as stable to be able to submit a registration dossier for the registration of fosravuconazole in Sudan. We still have a number of questions that are arising from the randomized clinical trial. So like, first of all, what is most important, drug or surgery? Because within that clinical trial, we provided treatment for 6 months. We conducted surgical excision of the mycetoma mass at 6 months, then continued treatment for 6 months. Are we able to treat a patient just with drugs alone? Do we require surgery for all patients? And if not for all patients, which patients should we do drugs only, and which patients should we do drugs or surgery? Then, of course, being able to look at the mass itself, we were not able to measure the mass above the skin, because looking at it in terms clinically, where we were just measuring it clinically, so total volume above and under the level of the skin. Then questions still arise about encapsulation, because even after surgical excision of the mycetoma lesions, after 6 months of treatment, you'd find that the grains are still present within these lesions. So do we need to look at other drugs that can be able to penetrate? Because we do understand with mycetoma, we have a very tough fibrous encapsulation of the lesion. Are we able to put intralesional beads within these lesions, or are there any other drugs that we need to look at, such as anti-inflammatories, to prevent this fibrous encapsulation? Then also looking at the timing and need for surgery. We have conducted expert meetings globally, where we discuss with a number of clinicians at what point they conduct surgery. For some clinicians, they conduct the surgery when they meet the patient, remove the mycetoma mass, then start the patient on treatment. Within our clinical trial and also within the Mycetoma Research Centre, where we based most of our activities, it was done halfway after 6 months of treatment, conducting the surgery, then continue with the treatment. Or should we conduct it at the end after finishing 12 months of treatment? So these are still some of the questions that we need to be able to answer. And also, can surgery be avoided if possible? There is someone writing on my screen. I don't know how that's happening.
Please stop this. Please stop this.
I don't know how to stop that.
Samira, can you mute everybody?
Everyone is muted, Prof. But there's someone just trying to write on the screen, and I'm trying to figure out how can we stop it.
Okay.
Okay.
Sorry for that, Borna.
No, it's okay. Let me try resharing. Yes.
Yeah.
So as I mentioned,
good.
whether surgery can be avoided and how to conduct this surgery. Then, of course, we are now looking at new treatments, being able to see that, first of all, itraconazole that has good efficacy when there's compliance. I have to repeat that quite a bit because the Mycetoma Research Centre, of course, with Prof. Fahal, with the clinicians and the pharmacists, ensured that these patients were taking their drugs on time, were taking them every single day, because within a normal clinical setting, ensuring patients take 4 tablets every single day for 12 months is a very difficult feat. So we usually ensure that when we're talking about efficacy of itraconazole of greater than 75%, is we're talking about in a clinical trial setting where we had drug adherence of greater than 90%, meaning that almost all the patients had drug adherence of greater than 90%. So looking at new treatments, because of course, even with fosravuconazole, we're still looking at 12 months of treatment. We would like to be able to have new drugs that might prevent us having surgery if possible, shorter duration of time if possible. So those are part of the drugs that we're looking at the DNDi target medicinal profile that we're working. So we have Mycetos, open source farmers that are looking at new compounds, also looking at other activities and how the pathogenesis of Mycetoma specifically, the role of melanin and how to be able to manipulate it, screening of new antifungal drugs. I know the MRC and also quite a number of Mycetoma researchers are working on new antifungal drugs. DNDi is also looking at how we can be able to repurpose other drugs for this indication of Mycetoma. But we do understand preclinical studies are needed. We need to conduct translational work and we need animal models to be able to replicate these infections. Of course, looking at new regimes, shorter duration, looking at whether we need combination treatments, maybe an anti-inflammatory drug, timing and need for surgery as already indicated. Then, of course, efficacy of greater than 90% with a drug that is oral, affordable, and safe. Then looking at adjuvant treatment, especially for some of these severe cases, we have bacterial superinfection. We need to be able to standardize the diagnostics and treatment, then looking at modulation of inflammatory response. Looking at the gaps that still remain despite the clinical trial and some of the activities. Of course, we do not have a purely curative treatment because, as mentioned, for the study, especially with the surgery, we were doing the surgical excision of the mycetoma mass. This is a treatment plus surgical excision. Then for some of the drugs, we find that itraconazole is not in the essential medicine lists in a number of countries, especially in Africa, and quite expensive. Thus, poor compliance and poor efficacy from patients. We still have very limited research and development programs. As far as I know, I don't think there's any other clinical trial ongoing for Mycetoma at this particular time, and we need quite a number of research and development programs that need to be conducted to be able to find new treatments. In terms of the pathogenesis and basic epidemiology, that is still also a gap. In terms of national control programs, as I was aware, it was only Sudan at that particular time that had a national control program. So a number of countries, and I know the WHO, those are part of the strategic imperatives that they have in terms of including mycetoma in the national control programs. So what are the enablers for this? What I've mentioned, such as the MRC have done or did quite a bit was in terms of community awareness and early detection of the disease before it spreads and requires amputation or it becomes much difficult to manage. Access to diagnosis, we need to work with partners to be able to have a point of care diagnostic tests to be able to deal with the disease much earlier. And of course, rehabilitation services. I know this was being done quite a lot in Khartoum in terms of providing these patients with tools and also arming them with skills to be able to take care of themselves. Surveillance, more studies need to understand the burden of disease. And then, of course, this being an endemic problem, we need to do systematic study of the disease so that we can have stable improvement of the population's health through health cooperation work. Some of the work that DNDi is doing to tackle this, first is the translational research. We are working on the development of a new translational mouse model to guide further research and development in new mycetoma, of course, working with the Mycetoma Research Centre, Erasmus Medical Centre, and Antwerp University. We also need to close the mycetoma knowledge gap, and we are currently conducting epidemiological studies in Senegal, Ethiopia, and India to uncover the mycetoma burden, raise awareness, and contribute to the creation of national control programs. And in Sudan, we would like as soon as possible to be able to implement the early access cohort protocol, in which we will be able to provide fosravuconazole 200 milligrams to patients with mycetoma. And with this, we hope to collect additional safety and efficacy data to guide our future multi-country phase 3 trials on fosravuconazole. In terms of access to treatment, as mentioned, we are focusing on registering fosravuconazole in Sudan and developing a global strategy for registration in other countries to promote patient access. In the short term, we are facilitating access to itraconazole and trying to see what are some of these barriers to access of itraconazole in quite a number of the countries. So these are some of the studies that we are working with quite a number of partners. In Senegal, we are working with UCAD, which is a university, Cheikh Anta Diop de Dakar, and the Fungal Infection Study Forum in India, where we are conducting retrospective data collection and have so far collected over 1,500 records of suspected or confirmed mycetoma cases over the period of 2014 to 2023. This work is being led by Prof. Doudou Sow from Senegal, and Prof. Shiva Prakash and Prof. Aruna Kole Chakrabarti in India. In Ethiopia, we are being led by Arba Minch University and Bahidar with Professor Wendemagen, where they're conducting a field survey. Currently, they have already screened over 35,000 people. We plan on screening of 100,000 people in 4 main regions, that is Amhara, Afar, Tigray, and South regions. And currently, they have found over 50 suspected mycetoma cases that we hope to conduct confirmatory testing for mycetoma. We also want to be able to understand the social, behavioral, and economic determinants affecting mycetoma prevention, healthcare seeking behavior, and management. And we are conducting this with the African Institute for Health and Development, together with collaborators from KEMRI, USCDC, Surgery in Turkana, and Lodwar County and Referral Hospital in Turkana County, where we want to be able to develop evidence-based recommendations for enhancing prevention, treatment, and overall quality of life for those who have been impacted by mycetoma. Thank you so much for your time.
Borna, as usual, nice, elegant, educational presentation. We're very proud to have you in this club. Really, it was very much aspirating for the future collaboration and working together for the mycetoma patient around the globe. We are really very grateful for all the work you are doing for the mycetoma in Sudan, India, Senegal, Ethiopia, and Kenya. You are the star of the show for this work you are doing. Thank you very much.
Thank you.
The floor is open for any discussion and comment. I can see now Professor Ibrahim Bani attending this meeting. Professor Ibrahim Bani is a professor of epidemiology and community medicine. He is an eminent professor from different university in the United States and Arab Emirates as well.
Yeah.
Thank you very much for joining
Welcome.
us, Professor Ibrahim Bani.
Thank you, Professor Bahal.
I see Ali has his hand up.
Yes, thank you very much, this is Ala Abdullah. Thank you, Borna, for your presentation. And thank you for this nice and educational presentation. And I would like to extend my sincere gratitude to you and the entire DNDi team for outstanding efforts in managing and advancing research on neglected tropical diseases, and particularly in mycetoma. So your dedications and commitment to develop better treatment, improving the life of patients in endemic regions are truly commendable. Also, the impact of DNDi work in addressing the challenges of mycetoma is invaluable. And I deeply appreciate all ongoing researches, collaboration, and advocacy that you and your team led. And it's my privilege, it's a privilege to witness and engage with such meaningful contribution to global health. I have some raising questions regarding the DNDi. Are there any plans to expand the clinical trials of fosravuconazole to other endemic regions beyond what that done in Sudan? And the second one is, how does DNDi work within with the governments, policymakers to integrate NTDs treatment programs into national healthcare system? And also in your presentation, you say something about the approval of new treatments in the countries. I'm asking, how is DNDi working to accelerate a regulatory approval for these new treatments? And maybe last question would be, what are the policies or recommendation does a DNDi advocate to enhance the treatment access and adherence to national global levels? And is there any digital or remote monitoring tools to track a patient adherence or something like that can be done in this area of adherence to treatment for the patients with neglected tropical diseases? Again, thank you very much for your presentation and for your work and efforts at DNDi.
Thank you so much. Really appreciate the kind words. Going into the questions, yes, we are looking at expanding beyond Sudan. As I mentioned, with the fosravuconazole randomized clinical trial that we conducted at the Mycetoma Research Centre, it gave us some very good safety and efficacy data. But our population was limited only to the Sudanese population. So as we look at expanding access for a global recommendation, we definitely need a more diverse population, and also to look at other causative organisms. That is why we are first conducting the epidemiology studies. As I mentioned, we are currently in India, Ethiopia, and Senegal, and Kenya. The first reason for this is to be able to understand the burden of disease within these countries. Second of all is to understand the most common causative organisms within this country. As mentioned for stravuconazole, currently the data we have is specifically for Madurella mycetomatis. So we would like to understand what are these causative organisms in the country. As we gather this data, we hope that this will now guide a multi-country study that we hope to be able to implement quite soon within these 4 countries that I have mentioned, as they're the ones we currently have data on. But as we also expand, we would like to look at other endemic countries. We are aware of countries such as Mauritius, Chad. We also have Brazil and Mexico, which has quite a lot of mycetoma, but mostly actinomycetoma. And we have been concentrating on new mycetoma. That is why we are also looking at India. So very soon we should be able, following the data from our epidemiology studies, be able to properly design an implementation study for stravuconazole within these other countries. Looking how we can be able to integrate this data. The first thing, whenever we start a clinical trial, apart from working with these academia or implementing institutions, we ensure that the ministries of health are a big part of the activities that we are conducting. We ensure that within the clinical trial itself, we provide progress reports, we provide them with data from our recommendations from our Data and Safety Monitoring Board, and we also provide the clinical study report at the end of the clinical trial. And this is what made it actually easier in Sudan, because on completing the clinical trial, we went to the regulatory authority, the National Medicines and Poisons Board, and we presented our clinical trial results. At that point, we were looking at it towards movement towards registration. But looking at our data and realizing the efficacy of the drugs, they saw that there was an urgent medical and public health need, and actually provided us with an early access authorization to be able to use stravuconazole under the Mycetoma Research Centre for patients with mycetoma in Sudan, as we wait for the full registration of the drug. So we find that this integrating these stakeholders within our clinical trials makes it easier to be able to implement our studies, and at the same time, when we have a product that is available, for it to be easily acceptable. Looking at it in terms of a global recommendation, we've already had quite a number of discussions with the World Health Organization. Last year, we had a WHO consultative scientific advice, which DNDi raised, in which we presented our clinical trial results and looked at what would be required for WHO pre-qualification of stravuconazole and what would be needed for the recommendation of stravuconazole for the treatment of mycetoma. So it was at this particular time that it was indicated that though the clinical trial results for Sudan were good, but they were not adequate for a global recommendation. And that is why we still require to conduct this multi-country study to be able to collect additional safety and efficacy data from diverse populations. In terms of access, we're looking at being able to provide for stravuconazole through this global access strategy. But in the meantime, from our clinical trials, we did understand that itraconazole actually has very good efficacy. So itraconazole has not put is available in some countries, though it can be quite expensive. But we do know that with adherence, that it can have very good cure rates. So this is information that we are already discussing with a number of healthcare providers. So countries like Kenya, where itraconazole is actually in the national essential medicine list. So that is why we are conducting the social behavioral study in Turkana, because a country like Kenya, which has itraconazole, and the county hospitals are provided itraconazole, why are patients with mycetoma in Turkana not receiving itraconazole for mycetoma, considering that we know that it works? So that also goes into your last question. Even as we recommend the itraconazole to be used for treatment for patients, we know compliance or adherence is the most common issue. So we need to be able to understand how we can be able to monitor these patients. So within the clinical trial, we used to conduct drug accountability. The patients are provided with the drugs for a specific period of time. In a specific period of time, then they bring back the wallets of the drugs, and the pharmacist counts it to make sure that they took the medication at the right time. We were also doing pharmacokinetics, where we were looking at the drug levels within the patients, just to make sure that drug adherence. But definitely, there is a very great need to be able to develop digital monitoring tools, maybe as reminders to patients, to ensure that they also adhere into taking their medication.
Borna, I see Dr. Abdullah, you have raised hand.
Hello, good afternoon for everyone, and very deep thanks to Dr. Borna for this wonderful presentation. We enjoy your presentation, and we learn a lot about the the initiative for neglected diseases, the neglected drugs, because it's not only for providing drugs, but also for doing research and development for better understanding of the pathophysiology, and also better understanding of best animal model for the test efficacy. And I have two questions. The first one regarding the research and development for the better understanding of grain formation, if there is any like idea, or how can we understand the formation of the grains, and how can we develop the possibility of developing in vitro grain model by mimicking the clinical situation which the fungus usually face inside the tissue, because as we know, the fungus grow in a completely different morphology in a culture media, which is not like the grain formation. But what I know that many fungi also have the ability to form grains in vitro, and this could be a very good model for testing drugs and also for understanding of the grain formation in vitro, in vivo. This is my first question. And the second question, do you have any activities in Eritrea or not? Because I am now currently in Kassala, in eastern part of Sudan, and it's a city which is like 15 kilometers only from the border with Eritrea. And I found that there is many cases of mycetoma are coming from Eritrea. Some of them eumycetes, and some of them actinomycetoma as well. Thank you.
Okay, thank you very much for the questions. I can start off with your second question. As you may be aware, we want to conduct the early access cohort protocol that I mentioned, actually at Kassala, where Profahal and the team with the Mycetoma Centre at Kassala University Hospital. So we will be looking at quite a number of the mycetoma patients who are there, and also understanding the closeness with Eritrea. Currently, we are not conducting any clinical studies in Eritrea, but those could be future countries that we could be looking at. Because for this particular early access cohort protocol, we are adding safety and efficacy data to the Sudanese population data that we had already collected in the phase 2 RCT. So within this particular study, we will also still be looking at the Sudanese population. But as I mentioned, as we look more and more into endemic countries, these are countries that, of course, within the mycetoma belt, and who might have access to more mycetoma patients that we can include in our multi-country studies, we would quite be looking at. Into your first questions, of course, grain formation as part of pathogenesis is one of the big questions that we have within the program. Being able to understand, apart from the grain formation, the encapsulation, how we can have drug penetration within this fibrous tissue and also into the grain itself, to be able to achieve cure. Current data which we have is from the in vitro testing that we've had with the different drug molecules. At the same time, Wendy and the team, a lot of the work that they have been using in vivo have been with the Galeria model. We are hoping right now with some of the new partnerships, especially with Wendy and the team from Erasmus and also from Antwerp, to be able to have mouse models, because we've not been able to have specific animal models that are able to mimic the grain formation and also the encapsulation as how it occurs in humans. The Galeria models have been good, but they've not been able to mimic as much as we need for the drug development that needs to occur. So we are working on the preclinical mouse models to be able to provide us with a better idea to look at the pathogenesis within these animal models that would mimic how this is formed within humans. I'm seeing Profile's hand up. You'd like to add something? Yes?
Yeah, fine. Thank you very much, Borna, for this explanation. I would like to introduce to you Dr. Abdullah Osman. Dr. Abdullah is an eminent microbiologist. He had his PhD in mycetoma quite a long time. He was the first ever used the PCR to identify the mycetoma organism by this molecular diagnosis. Again, he was used an animal model in the past for the mycetoma studies. Abdullah Kani, and now he is based at Kassala. He will be an asset to the Mycetoma Research Centre at Kassala sister center there, where we're going to conduct our new study on the early access. Abdullah, can you tell us about your experience with the animal model when you was there doing that work in Erasmus quite a long time?
Yeah, thank you very much, Professor Fahal. We had a chance to develop a mice model in PAPZ mice a very long time ago, and we found that the pathology and the grain formation is exactly typical to what we were seeing in histological structure coming from human biopsies. And the only challenge was the very high dose we need to use for establishing the grains. Unfortunately, the mice model in any way is a very short living animal model, so you can't do a very long study, but the grains has been formed within 7 to 9 days, which is relatively short time after the inoculation. And some of the mice were died because they had a super infection, and mycetoma, we were able to isolate it from different internal organs from the mice, but some of them resistant the inocula, and they develop grains very shortly, as I told you, within 7 to 9 days. This could be a good model for testing, but also I am insisting that we should also think about the alternative, the in vitro model, because the in vitro model will be much easier and much reproducible, and we can control so many variables in that type of models. Thank you.
Yes, we are using all of them in parallel currently with the different partners, just to be able to look at quite a lot of the parameters at the same time. And Dr. Abdallah, if you have a paper on the work that you did, it would be great if you're able to share this with me.
Sure, I will share it.
Thank you very much.
Welcome. You're welcome.
Prof, I see you have a raised hand.
Yeah, Borna, in this session we have the pleasure to have many young researchers joining the MRC. One of them is Ala Al-Maleh. She's want to work on the biomarker for the mycetoma diagnostic study. I shared it with you yesterday. Yeah. And then we have Lamis Al-Khair. She had her PhD just finished in France a few months ago. And she had another proposal to study her molecules at more depths. And again, we have Samira, and we have Lumna. Lumna, she wants to do a lot of work now on photodynamic on the mycetoma treatment. Now she is in Japan doing her master and hopefully her PhD soon. So we have a young group of researchers and scientists. I'm sure this will going to have a lot of impact on the mycetoma research community in the future, coming with more ideas, more solution for the mycetoma patient globally. So we're very proud to have this young group of
Definitely.
young researchers. I sent you around 3
It's
proposals last
wonderful
week.
news.
Yeah, 3
Yes.
proposals. Most of the contributors of these 3 proposals are here with us this afternoon. I am sure they will be very happy to communicate with you and to see how we can go forward with these 3 proposals, addressing the mycetoma pathogenesis at the level of the tissues, at the level of the grains, and the grain formation, how we can overcome the problems with in vitro poor response to antifungal drugs. In vivo antifungal drugs failure.
This is amazing. Yeah. So of course, as the gaps are being filled in terms of R&D and people involved.
Yeah. Ala, can you tell us about your ideas? Ala?
Yes, I plan to conduct a research for biomarker to study the genetic, and then to analyze the RNA, DNA, and then to analyze the RNA transcriptomic. And at the end, we conduct in vivo study and in vitro study to validate the biomarkers that can be later on used for diagnosis and prognostic use. This is the brief what I plan to do.
Okay, Marwa, can you tell us about your repurposing drug for the mycetoma? Marwa?
Hi, Prof. Hello.
Yes.
Hello, everyone.
Good afternoon, Marwa. Yes.
Good afternoon, Prof. We plan to make a repurposing for drugs to validate or to know what the available drugs now, what one of them can be used for mycetoma. The planning of repurposing is conducting firstly by in silico testing. We plan to make testing for all used drugs against certain types of target in mycetoma. This target is very essential for grain formation for mycetoma. And after that, we want to validate the results for in silico testing, and then we can make modifications, a slight modification on the structure, on the structures. When we exist some drugs which is active in this targeting of mycetoma, and then we conduct synthesis for these drugs to evaluate it in vitro testing and then in vivo testing.
Thank you very much, Marwa. Limis, can you give us a brief talk idea about your plant work?
Yes. Firstly, we want to.
No. Thank you, Marwa. Limis.
Thank you, Prof.
Yeah, thank you, Marwa. Thank you, Marwa, very much. Limis is there?
I think he left, but Lubna is here.
Lubna, yes, tell us about your photodynamic study.
Hello, good evening to all of us. Thank you so much,
Good
Professor
afternoon.
Ahmed.
You are from Japan. You are in Japan now. This is still your afternoon.
Yeah. Okay.
Yeah.
We have a different compound that serve as photosensitizer. They emit reactive oxygen species under light. So I need to test them for mycetoma, Madurella mystomasis especially. We have around 20 samples. And I will use it for in vivo and in vitro study. For in vivo study, I will use Galeria malaria larva, but I hear that Galeria malaria larva from Dr. Borna now, it's not suitable for mycetoma. So maybe I shifted to mouse model. Can you give me your idea about choosing if Galeria malaria or mice model? Thank you so much.
Okay. So Borna, this is an example of our young researchers. I'm sure they are going to do a lot of work in the future for the mycetoma patients management and to improve the quality of science we're producing in collaboration with DNDi. Thank you very much.
Thank you so much, Prof. I think this is just wonderful news, hearing all the different activities ongoing. So definitely, I'm sure we will catch up more in terms of the activities ongoing and how we can collaborate on this.
So, Borna, one of the questions in the chat was asking, is the new super bioavailable suba itraconazole, has it been tried for
Sorry, I lost you a bit, but you were asking about the suba itra?
Yeah, well, someone has been asking in the chat, has suba itraconazole been tried for mycetoma?
Yes, there's some preclinical work that is ongoing, but we have not implemented it yet within a clinical trial. But definitely in terms of more availability in terms of the drug. But as I mentioned, currently our investigational product of focus is fosravuconazole. But as we look towards combination treatments in the future, we would look at whether shorter regimens, maybe the suba-itra or fosravuconazole would work better.
Okay.
But currently no clinical trials, yes.
Okay. Prof, I see you have a raised hand.
Yeah, just at the end of this session, I would like to mention that Borna was very much modest in mentioning the relation between the Mycetoma Research Center and the DNDi. Actually, the relation, it is both long and interesting. It started in 2013, more than 10 years. We had a lot of support from DNDi. DNDi supported the Mycetoma Research Center and the Ministry of Health in Sudan to introduce the mycetoma at the WHO neglected tropical disease list. The DNDi had supported the first ever double-blind clinical trial at the Mycetoma Research Center. DNDi had trained our staff on a good clinical trial, good clinical practice, good medical laboratory practice, and even good financial practice. The DNDi has supported our activities at the field. We developed the Mycetoma Peripheral Satellite Center at Onsa Village, Eastern Sinnar, and the DNDi has supported the lab there, the ultrasound machine, and a lot of activity was conducted at the field that was from the support we got from the DNDi. Recently, the DNDi has supported a new project, and that is Mycetoma Behind the Lens. And again, this is a new activities for advocacy awareness, making, we are in the area of the open science. We are trying to avail all our photos, images, and videos publicly available for researchers and for international community to learn more about the mycetoma. And again, this is one of the best, I think, program for advocacy and awareness on mycetoma. And hopefully we're going to conduct the early access trial at Kassala State on the vosarovaconazole, helping mycetoma patients and this. So the collaboration between the MRC and the DNDi, as I mentioned, is both long and interesting, and we are very much grateful and thankful to the DNDi for what they're doing over the last more than 10 years. Thank you, Borna, for these activities, this support. We're looking forward for really a very collaborative work in the future. Thank you very much.
Thank you so much, Prof. And thank you to the MRC and team and all the great work you've been doing for Mycetoma. As you're seeing, you are growing and growing even outside as more and more people get involved, I think, in the end for the benefit of Mycetoma patients.
Thank you.
I would like, ending our session for today, I would like to thank you all for joining us here today. And Dr. Borna, we're so thankful for joining us today, and we hope that we join us in further sessions. And I'd like to thank our dear audience. Thank you so much, and until we meet again, thank you, and have a wonderful time.
Thank you.
Thank you. Bye-bye.
Thank you so much.
Thank you. Bye-bye.
Bye.